Hey, welcome you all in Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj. I'm pediatrician by profession, teacher by passion. So today we are continuing our amazing series of AIIMS SS DM Neonatology Fast Track Rapid Revision. Okay, we have discussed many topics before. Today's topic is Neonatal Orthopedics, which is actually ignored topic, but it is very important. Many questions comes from this. Okay, so hope you get benefited from previous series or previous videos on neonatology. Okay, so do share, like, and subscribe before we start this lecture. Without further delay, we are starting our discussion of neonatal orthopedics. Okay, first thing first, birth injury. Okay, cephalohematoma, caput secundum, subgleal hemorrhage. We know. I just want to take your attention here. This is cephalohematoma. As all we know, just a revision. Okay, so this cephalohematoma, it is actually a collection of blood. It does not cross suture line. On the other spectrum, this is caput secundum. This is edema and it crosses the suture line. Okay. Subglial hemorrhage is collection of blood between scalp and glial aponeurosis, and it usually crosses midline. Generally, subglial hemorrhage contains approximately 260 subglial 260 ml of blood that may lead to anemia, hypotension, and hyperbilirubinemia in neonates. So this has to be understood. Okay, so as we understood, hypotension and anemia and jaundice subglial hemorrhage, cephalohematoma usually resolve within 4 to 6 weeks. That is important. Okay, skull fracture in newborn, mostly they are linear and depressed, mostly due to vacuum extraction, forceps application, and a depressed fracture usually require neurosurgical intervention. So in any neonate, if you found depressed fracture, it requires neurosurgical intervention. Key point. Okay, then going forward to uh, sternocleidomastoid tumor. Okay, so this is basically presents with torticollis with the head tilts towards injury site. If injury site is on right side, head will tilt toward this, and surprisingly, it has 10% association with developmental dysplasia of hip. So we have to do stretching exercise of affected muscle, leading to recovery of this condition in 3 to 4 months in around 80% cases. Okay, persistent deformity may require surgical intervention, as we all know. So, which is most common cranial nerve injury in newborn? This is facial nerve injury, mostly is due to forceps application in uterine fibroids. Okay, brachial plexus injury, all we know. Erb's palsy is due to C5, C6 nerve root injury. Sometimes it involves in C7 nerves. Okay, so in this Erb's palsy, intact gag grasp reflex has a good prognosis. Okay, you found a patient of Erb's palsy in neonate and his grasp reflex is intact. It is a good sign. This was previously asked question PYQ. Okay, total brachial plexus injury can occur, and another thing is clumpcage palsy, that is C7 C8 T1 nerve root injury. It is very rare. Okay, clavicle fracture is the most common injured bone during delivery. So most common bone injured during delivery is clavicle. Femur fracture, humerus fracture are found in breech presentation. Okay, so we discussed some fractures. Now we discuss core neonatology topic, that is metabolic bone disease. This was earlier called as osteopenia of prematurity. You have to remember this. The metabolic bone disease, earlier its name was osteopenia of prematurity, but it has been changed to metabolic disease, bone disease of newborn or neonates now. Okay, so when it presents, this presents within 5 to 11 week of postnatal age. Again, it is very important. Metabolic bone disease, though micro changes starts just after birth, but it manifests present as 5 to 11 week window, because this is where manifestation of metabolic bone disease, bone deficiencies start to present. This is PYQ. Okay, so what is the definition of metabolic bone disease? It is a reduction of bone mineral content. Okay, bone mineral content is decreased with, if we compare to age, sex, gestation, etc. Means at normalized population level, if we compare reduction of bone mineral content, it will be called as metabolic bone disease. This is a raw definition. We'll discuss criteria of this definition later in this slide. Okay, so it affects 16 to 40% of VLBW or ALBW infant. Point to note. So what are the risk factors? How we can prevent this? If we know this entity, we can prevent this. Okay, so many risk factors are there. If placental insufficiency is there, yes, you should be aware. Maternal vitamin D deficiency, that's why today's era mothers are usually have supplement of vitamin D to reduce this condition. High number of T repeats, this was actually USMLA repeat. Okay, so this is high number of TA repeats is associated with metabolic bone disease. Male gender, just point the actually point B to noted. Male gender is have more association with metabolic bone disease. Prematurity, all we know. Inadequate intake of calcium and phosphate, obvious. Vitamin D deficiency, it's very obvious. Immobility, yes, it is very obvious. Liver disease, because all metabolism happen in liver. Renal disease, because renal hydroxylation of vitamin D by alpha 1 alpha hydroxylate, all we know. Drugs, using drugs, just caffeine, steroid and diuretics. So just you have to remember these drugs. Caffeine, steroid and diuretics can lead to metabolic bone disease. How you will prevent this? Early enteral feeding, you can prevent this. Okay, by reduction of parental nutrition. Early fortification of human milk in babies who are at risk. Who are at risk? We have discussed just now. Physical activity like passive range of motion and joint compression can improve bone mineralization. This is important, and this is traditional practice in our country, which is having passive range of movement exercise. Just gentle exercise of baby is required, which prevents baby to from metabolic bone disease. So this is overview of metabolic bone disease, risk factor, prevention, and its presentation. Okay. Now we come forward how we will diagnose this metabolic bone disease. Look, this is very interesting and you have to stay focused on this. Okay, you have to do serum phosphate and ALP levels. Okay, if serum phosphate is less than 5.6 milligram per deciliter, alone serum phosphate is not sufficient. You have to do ALP levels. It should be more than 900 international units per liter. Okay, so you have to remember serum phosphate less than 5.6 milligram per deciliter and ALP is more than 900 international units per liter. Okay, so sensitivity specificity, this test is 1700%. This is important. Okay, serum PTH, serum PTH of this diagnosing metabolic disease should be more than 100 picogram per ml. Okay, but just remember this phosphate and ALP value. This is sufficient to remember, sufficient for exam. Tubular reabsorption of phosphate. Okay, more than 95% with low or normal PTH suggestive phosphate deficiency. If you found tubular reabsorption of phosphate is more than 95%, normal PTH, it will suggest phosphate deficiency. We'll discuss this phosphate significance later in treatment. Okay, if you do X-ray in these patients in the neonatal infants, okay, so it is one score is used that is called as Q score. Q score was previously asked in exam, which score is used for analysis of metabolic bone disease in newborn infant. It is Q score. Okay, but the important thing you have to remember, only after 20 to 40% bone demineralization it appears or it is evident. It has been classified into grade 1, grade 2 and grade 3. Grade 1 is presence of bone rarefaction. Grade 2 is metaphyseal alteration, shadow and subperiosteal bone formation. So this question can be asked in exam. Subperiosteal bone formation is grade 2 of core score in metabolic bone disease, and grade 3 is spontaneous fractures. Okay, DEXA is very popular nowadays for bone mineral density. So in newborn or infant we also use DEXA. So if we do DEXA, there are many range, but generally BMD is more than 0.068 gram per centimeter square. It is considered normal. Below this, it is abnormal. Okay, so definition we will not use, but many parameters of this we will use. We mostly use phosphate and ALP levels. Okay, where we will take DEXA. This is extra edge, lumbar spine, forearm, and calcaneus used. Quantitative ultrasound is like with ALP, calcium, phosphate, vitamin D levels, and bone transit time can be used. This is advanced or operator based investigation, so this can be used. So in nutshell, we can use serum biochemistry in form of serum phosphate, ALP, and PTH level. We can do X-ray, we can do DEXA, and we can do quantitative ultrasound to diagnose this metabolic bone disease. Okay, so treatment of metabolic bone disease of prematurity. Okay, we'll discuss this, but before this we'll discuss this condition. Okay, this management of metabolic bone disease approach is important. Just remember, in neonatology or in pediatric, just treatment is not sufficient. You have to be in a proper way or proper approach towards disease. Same is true for metabolic bone disease of newborn. Okay, so you have to target population first thing. Gestational age less than 30 week, just be aware more chances of metabolic bone disease, and gestational age 30 to 34 with one of the following risk factors. Risk factors are parental nutrition more than 2 week, cholestasis, and use of bone active medication, that is steroid, loop diuretics, methylxanthine for more than 2 weeks. Any one of the should be present. Mean 30 less than 30 week you have to screen everyone, but 30 to 34 week at least one risk factor should be there, that is parental nutrition more than 2 week along with certain drugs and cholestasis. Okay, you found your target population, your screen is ready. So in screen what you will do, which is important, serum calcium, serum phosphorus and ALP, these three things will be used. Not DEXA, not X-ray, not PTH. Even PTH is not used for screen, that is important to remember. Okay, when you will screen, that is also important at 4 week of just post birth, and at 2 week if TPN since birth. Generally will do at 4 week and 2 week if TPN since birth. It is somewhat like ROP screening protocols. Okay, so you have to remember at 4 week and 2 week in this condition for serum calcium, phosphorus and ALP you will do this testing. Okay, if you found these normal, means everything is normal. Okay, so monitor the every 2 week until discharge 40 week post menstrual age. So you have to, if your like a newborn is 32 week, you have to see this is these screening is normal. You have to follow these neonates till 40 week of gestation. But on the other limb, left side limb, suggestive of ALP, that is ALP more than 900, ALP is more than 900 and phosphate is less than 5.6 milligram per deciliter. These are two main parameters which are used in this condition. I have discussed earlier also. Okay, so what you have to do, you have to maximize supplements. What supplements we'll discuss after some time. If you are giving supplements like vitamin D, calcium, phosphorus, you have to maximize them. Okay, till as tolerated, okay, and continue discontinue any bone active medication as we discussed just now, okay. After that, repeat your screen after 2 weeks, okay. If response is there, all good, you can continue the supplements, but still response is not there, you will do second line investigation as discussed, x-ray knee, x-ray knee, wrist, serum PTH and 25 hydroxy vitamin D. Okay, two classical scenarios will come up in this. Just pay your attention. First scenario is PTH is more than 100 picogram per ml, but 25 hydroxy vitamin D is less than 20 nanogram per ml, means PTH is high, vitamin D is low. Second scenario will be PTH will be less than 100 picogram per ml and 25 hydroxy vitamin D is more than 20 nanogram per ml. Okay, first condition in which PTH is high and vitamin D is low, it is obvious that you have to supplement this patient with vitamin D, that is 2000 international units daily, plus maintenance dose for 3 months with adequate supplementation. This is clear, PTH is high and vitamin D is low, so you have to supplement that patient. Okay, if your PTH is low on the right side of scenario and vitamin D is above 20 nanogram per ml, you have to add phosphate supplement. Very important indication of adding phosphate supplements. Add on extra supplement of phosphate are required if PTH is less than 100 and 25 hydroxy vitamin D is more than 20 nanogram per ml. Okay, again you have to monitor serum calcium, ALP, phosphate every 2 weekly. 2 weekly will remain same. Okay, so when you will stop monitoring, where your ALP, that initially it was more than 900, if it comes down around 500 or 500 to 600, you have to stop, and phosphate is 4 milligram per deciliter. Okay, this again, this one thing was PYQ. Clinical scenario was given in AIIMS exam. A patient or neonate having cholestasis. So ALP was very high and phosphate was normal. In this condition, due to cholestasis, ALP is high, so don't consider ALP as an indicator of metabolic bone disease. Just use serum phosphate level, that is we have discussed here. Serum phosphate level 5.6 milligram per deciliter, less than 5.6. Don't use ALP here. Okay, fortification of HMF in breast milk is required. Okay, phosphate supplements in this condition, as we discussed just here. Okay, if PTH is less than 100, you have to add phosphate supplements. So phosphate supplements dose is important. They should be started at 20 milligram per kg to maximum 50 milligram per kg. So this was treatment protocol of this metabolic bone disease. You have to pause this video here and revise these treatment protocol again, because this is very important to understand this for practical point of view, for exam point of view, and your clinical practice point of view. Okay, so metabolic bone disease treatment as we discussed. So first thing, it is very required, calcium phosphate ratio should be 1 ratio 7, 1.7 ratio 1. Okay, so this ratio actually in preterm infant is different, but generally it is 1.7 ratio 1. Vitamin D, okay, vitamin D range is given 200 to 1000 international units per day, because many authorities believe other thing, like American Academy of Pediatrics suggestive of vitamin D intake 200 to 400 units per day. EPSGAN says 800 to 1000 international units per day. Okay, so this is generally we take 400 to 800 safer limit. Okay, calcium in enteral nutrition, parental nutrition treatment, this is different value, 150, 75 and 20 to 80 you can remember. Phosphate is, if you don't want to remember, just remember with this ratio 1.7 ratio 1 and you can derive this just remember calcium values. Okay, going forward to another topic which is important, developmental dysplasia of hip in newborn. This is often ignored topic by pediatrician, but it is our part and parcel of our today's practice because many newborn come up with this condition. Okay, and primary care of contact is pediatrician or neonatologist. So this condition actually happen in 1 to 2 every 1000 birth. Okay, so this is important. This is more common in female. So female DDS, developmental dysplasia of hip, is more common in female, and after some time we will discuss CTEV, that is orthopedic condition. It is more common in male. Okay, so what are the risk factor for DDH? Breech positioning, all we know. Family history of DDH, limited hip abductions, Talipes, female sex, swaddling, large birth size, first-born infant. These are actually risk factor for DDH. You have to remember all these: breech, family history DDH, limited hip abduction, Talipes, female sex, swaddling, large birth size, first-born infant. You have to remember them all. Okay, so approach of DDH, you have to remember. You found some things abnormal in newborn examination. What you have to do, just inquire if their history of DDH or breech delivery is there or not. History is there. Yes, history is there. You have to do physical examination and screening test you have to do first. This is wrong practice at day one to go for USG. Basically, you have to do examination, that is normal physical examination, and screening test. Two screening tests are used, Barlow and Ortolani test. Okay, so I will explain these tests in brief. What is Barlow test? Barlow means Bahar, that is out, exit. Okay, just remember this mnemonic. It will be very easy. Bahar, exit, out. Okay, so Barlow sign. What happen in this condition? Examiner or doctor wants to dislocate hip. It is very cruel thing, but you have to remember. Tries to dislocate hip by abducting and pushing posteriorly. So in this condition, you are by adducting. Sorry, in this condition, examiner is adducting. Okay, adducting the hip, and examiner is pushing the hips posteriorly. Okay, examiner is pushing the hip posteriorly. By this movement, a click sound is heard, and generally hip used to dislocate this side. Okay, so Barlow is dislocation of hip by adducting and pushing the hip posterior side. Okay, so on the other hand, ortolani is if your uh, hip is means dislocated, you have to reduce or relocate it by abducting and pushing anteriorly. By abducting and pushing anteriorly. So this is reverse of ortolani, reverse of Barlow sign. So you have to remember these two, or Barlow sign and Ortolani sign. Barlow just is Bahar, it do dislocation, and Ortolani is relocation. And you have to remember in Barlow, examiners do adduction and posterior pushing, and Ortolani it does opposite, this abducting and pushing anterior. Okay, so coming back to our approach. Okay, we did examination and his screening by Barlow and Ortolani test. If your screening is negative, it is no DDA, just be sure. But if your screening is positive, then you have to do USG screening. Okay, send neonate to US for USG examination for DDH only after doing Barlow and Ortolani screening test examination. My message is clear from this. Okay, so USG screening test you have to send just after your screening test, but before 6 months of age, which is required. Okay, USG having alpha angle and beta angle. So you have to be, as a pediatrician, you have to be aware of these angles. Okay, the main point is vertical cortex of ilium. Okay, vertical cortex of ilium. If acetabular roof is making some angle with this will called as alpha angle. Okay, so acetabular roof and vertical cortex of ilium will be called as alpha angle, and vertical cortex of ilium along with cartilaginous roof will form as beta angle. Okay, more alpha angle is more reduced hip. Okay, so this is actually radiologist tool to examine this DDH and mention alpha and beta angles and to interpret them. But as a pediatrician, we'll know this. X-ray hip, as we all discussed, it can't be done before 4 months of age. So this is important point to remember. Just don't order X-ray hip in less than 4 months of old infant, because it is non-productive, not required. Okay, and USG screening you have to do before 6 months of age. Again, so you did your examination, you did screening test, you did USG, DDS diagnosis is confirmed. So what is the treatment? So first step is reduction of femoral head. Your femoral head is out, you have to reduce them. That is very important. Till 6 months of age, Pavlik harness is used, and after 6 months, hip spica is used. So this was PYQ. Pavlik harness is used up to 6 months of age, and after that, correction of reduction of femoral head, you have to do manual correction of acetabular dysplasia by serial X-ray monitoring, and surgical approach is required if this is not corrected even after that. So this 6 month Paulic harness was PYQ. Okay, so this is just see this can be asked in exam. So this is Paulic harness. Okay, this is lightweight, and this can be used as your till 6 months of age. This Paulic harness is used. So you have to remember DDH, important risk factor, how you will approach, what are the Barlow's and Ortolani signs, what are the USG alpha and beta angle, what is the treatment protocol in brief. So this is brief in DDH, for as a pediatrician should know this is required. Okay, another condition is congenital CTEV. Okay, Talipes equinovarus. The full form is full form is this congenital Talipes equinovarus. Okay, so this condition occur in 1 to 2 in every 1000 birth. Okay, more common in male. We have discussed earlier also. DDH is more common is seen in female, but this CTV is more commonly seen in male. Examination by Pirani scoring system is done. In DDH, we have discussed two Barlow and Ortolani tests, but in this condition CTV, we'll go step by step. Okay, Pirani scoring system. Okay, you don't have to remember all Pirani scoring system. Just remember these having scoring to 0, 0.51, and mid foot and hind foot things are used. Okay, so what are the mid foot and hind foot things are used? So medial creases, curved border, lateral head of talus. So lateral, what are the main thing lateral head of talus? Okay, uh, border of foot and medial crease, posterior crease, equinus or empty heel. Okay, just remember these will be enough to actually for this Pirani score. So medial crease, lateral border of foot, lateral head of talus, posterior crease, equinus, empty heel, and 0, 0.5 and 1 are the scoring method. Just remember Pirani method used for screening of CTEV. These are components. Okay, this is enough. Okay, so what are the components? We will remember these components as a mnemonic, that is cave. Okay, so in first image, this is the first image. Okay, in this you found Cavus. This is seen in mid foot. So this condition is cavus. Okay. Adduction, forefoot adduction. You have to remember this because they'll ask adduction happen where in clubfoot. So it happen at forefoot. So forefoot adduction. Whereas this is varus condition. Okay. Varus occur at heel and equinus occur at hind foot. Why we are discussing as cave format like cave pneumonic? Because it is important. We have discussed a component examination. Now next step is treatment. No x-ray USG is required because this is clinical diagnosis purely. Okay, so in this condition treatment is also from CAVE, means this is previously year asked question. Okay, so Pirani I'll highlight. Okay, cave. Yeah. First you have to correct cavus, then you have to correct adduction, then you have to correct varus, and then you have to correct equinus. Equinus should be corrected in last. This was PYQ repeatedly asked in many exams. Okay, so what is the method? So you have to do serial casting. Okay, this cast is called Ponseti method. This is also PYQ. It is generally changed every week. Okay, so you did serial casting by Ponseti method, but after that, if your residual hind foot equinus is remaining, what you will do? Percutaneous stenectomy is required. Next, okay, foot abduction orthosis means special shoes, CTV shoes they are called, which are required, which has to be, one has to wear these shoes till 3 to 4 year of age. Okay, this is Parkinson's onset. You have to remember this. Okay, so foot abduction orthosis, the child have to wear 3 to 4 years. Okay, what is the specification? These are actually 70-degree. These are 70-degree dorsiflexion or 70-degree dorsiflexion or sorry 10-degree dorsiflexion, 70-degree external rotation. So these image, this was PYQ image. You have to remember this. Okay, you have to remember this condition: 10-degree dorsiflexion and 70-degree external rotation, which is important. Generally these shoes one have to wear 23 hours a day for 3 to 4 months, and after that night time use for 3 to 4 years, and any surgical correction is done after 4 years. Okay, so this is a nutshell of CTEV. So here we completed this orthopedic part of neonatology. Hope you like this video. If you like this, do share, like and subscribe. We'll discuss another series, another